Hello there, this is Dr. Schminke, and today we're going to be talking about the contraceptive implant, which is a long-acting reversible contraceptive method. Currently, the only available contraceptive implant in the United States is called Nexplanon. There are others that are available overseas, and some of them have 2 rods instead of 1. This is a flexible, small plastic rod. It's about the size of a matchstick, placed under the skin in the upper arm. It releases progesterone in the form of progestogen into the bloodstream to prevent pregnancy, and it lasts for 3 years. When talking to your patients about using the Nexplanon, you should make sure they understand that it's very easy to insert, and removal should also be quick and easy. It's something that you do in the office. That we give an injection at the site prior to inserting to numb up the area so it doesn't hurt. That you will insert the rod just under the skin of inside upper arm of the non-dominant hand, and then you'll tape it up and wrap a bandage around the arm to keep it safe from bleeding for the several hours after insertion, and that it needs to be removed in 3 years. Complications related to insertion are very rare. When the time comes for it to be removed, the provider will inject a local painkiller, and again, the client will be awake for the whole thing. You'll make a small cut near the implant and use forceps to pull out the rod. The person may experience tugging or slight pain or discomfort, and the site will be sore for a few days afterwards. We don't need any stitches afterwards in most cases, and you simply cover it with a gauze and bandage and send them on their way. It's important for them to keep the area dry for 4 to 5 days after insertion and removal, and know that they should get in touch with us if they have a bright spot in their visual field before, or are seeing visual disturbances before bad headaches, if they develop jaundice, if they have any signs of infection or continued pain in the insertion site where they see the rod actually coming out, if they're experiencing unusually heavy or long bleeding, or if they think they may be pregnant. They can come back anytime that they want to have the rod removed for any reason, and you will provide them with that service. There's no routine visit schedule for people using Nexplanon, but when you do see them while they have a Nexplanon in place, be sure to ask if they're satisfied with the method, if they have any concerns about bleeding changes, or if there are any new major life changes or health issues that have been diagnosed, any significant weight changes. If the side effects are persisting and unacceptable, then maybe you can help choose another method. And if she wants to continue using the implant and has no new medical conditions, then you can talk about how much longer the implant can stay in and safely protect her from pregnancy. What do you think the most important thing is that you can do for women who are experiencing side effects? Counseling and reassurance is actually the key to helping women, because you're reducing their anxiety about what they are going to experience. That knowledge is a huge step towards the woman accepting the issues she might have at the beginning, especially with irregular or breakthrough bleeding, for instance. It's common and not harmful. You can recommend ibuprofen when the bleeding starts, and if that's not helping, then you can actually offer combined oral contraceptives for up to 3 weeks at a time. And if she's really having heavy bleeding, you can also encourage an iron-rich diet or iron tablets to prevent anemia. In the other end of the spectrum, amenorrhea, you can also reassure the client that this is common for some women, and just make sure you rule out pregnancy if the implant has just recently been inserted. If side effects are persisting and it's unacceptable to the client, then it's time to pick another option. In addition to bleeding, there are several non-menstrual side effects that women may experience. If a client experiences frequent headaches that are not migraines, you can reassure her that they are ordinary headaches that don't indicate a dangerous condition and should diminish over time. Standard doses of aspirin, ibuprofen, or Tylenol can be used to alleviate those symptoms. However, if the headaches are getting worse or occurring more often after insertion of implants, then you need to evaluate the headaches. Mild abdominal pain can be caused by many things, including enlarged ovarian follicles or cysts. Reassure the client that ovarian follicles or cysts usually disappear on their own, and the standard doses of painkillers or other local remedies will usually alleviate discomfort. To be sure the problem's resolving, see the client again in 6 weeks. There's no need to treat enlarged ovarian follicles or cysts as long as they're not growing abnormally large, that would be greater than 3 centimeters in diameter, or twisting or bursting. However, if the abdominal pain becomes severe, you need to see the patient immediately and fully evaluate her acute abdomen. This is especially true if the pain is occurring with other signs or symptoms of ectopic pregnancy, which we'll talk about soon in this course. Those symptoms would be abnormal vaginal bleeding or no monthly bleeding, in addition to severe abdominal pain. She might also be lightheaded, dizzy, or fainting. Ectopic pregnancy is a rare but life-threatening condition, and what that is when the pregnancy has implanted in the fallopian tubes instead of the uterus, or actually anywhere in the body other than the uterus. But most often it would be in the fallopian tubes. Clients who experience breast tenderness can try a supportive bra or use hot or cold compresses. And again, they may find some relief with Advil. And if they're experiencing weight gain, then you can talk about diet and healthy eating habits and exercise to see if that might help her control her weight. And if not, you're going to always, if the side effects are unacceptable, you're going to remove the implant and choose another method. The problems that I'm going to list on this table are related to issues around insertion, pain, infection. We would give oral antibiotics if the site became infected, and if there's no improvement, we would have to remove the implant. An abscess would have to be, an incision and drainage would have to occur, and we'd give antibiotics. And again, remove the implant if it's not improving. And of course, expulsion, whether it's partial or complete expulsion, we'd have to figure out a different form of care, or perhaps we would reinsert on the other arm if the patient really wanted to use that method. There are several issues that can occur, health conditions that can arise that would require switching from implants to another method. The unexplained vaginal bleeding, if you can't figure out what's going on with somebody's bleeding and you're concerned that it might be related to another health issue, then you may need to remove the implant so that you can fully work up the unexplained bleeding. If the bleeding is caused by a sexually transmitted infection or pelvic inflammatory disease, it's fine to keep the implant in. Migraines with aura are another reason to remove the implant and help the client choose a method that is free of hormones. And of course, a patient who develops blood clots, a DVT, or a pulmonary embolus, or someone who has severe liver disease or breast cancer, these are issues that require the implants be removed. This patient would need a method that is hormone-free. In addition, you may encounter women who have heart disease. Now, if a woman had ischemic heart disease or had had a stroke before getting the implant, it's fine to initiate use of the implant. But use of implants should be discontinued if these conditions develop or get worse while using the implant. Remove the implants or refer for removal if you don't do this yourself, and give the woman a backup method to use until her condition's fully evaluated. In summary, these are good options for many women because it provides long-term protection of 3 years. It is safe and easy to use because they just have to have it inserted once. It is highly effective and highly effective and readily reversible. It's appropriate for people who are of all reproductive ages, and there's virtually nothing they have to do once it's been inserted. It is true that irregular bleeding patterns can be a problem for some women, so it's important that you thoroughly counsel them before providing this method of contraception. Thanks for your attention and have a good day.